Hi everyone, it's Karen here, and welcome to Series 4, Episode 3, I think that's right, of the Eve Peel's online show, Probably Nothing. So, as you can see, and I did this last week as well, I feel very professional. My name is Karen Hobbs. I'm a very nice Karen, I promise. I promise I'm one of the good ones. And I work at the Eve Peel as the Cancer Information Officer. I've been with Eve for a few years now, and I have the enormous privilege of running their information service, Ask Eve. And I run it alongside a gynae cancer nurse, Tracy. I'm not a nurse myself because, we can't have supermodel looks and nursing qualifications. It's just too much for one person. So I run the service with the wonderful Tracy, who you would have seen last week when we discussed treatment for ovarian cancer. We started Probably Nothing with Series 1 back in June last year, June 2020, because we decided it was time to bring you a weekly live online platform where we can discuss different gynae health topics, different gynae cancers each week in hopefully what is an interesting and accessible way, and kind of getting rid of that sort of medical jargon and making it easy to understand and busting any myths. Because we so often here at Ask Eve, we get people kind of emailing and calling and saying, first of all, oh, I'm sorry to bother you. And I said this last week, and I want to say it again because it's so important. Please never ever apologise for asking a gynae cancer service a gynae cancer question. That is quite literally what we're here for. And if you didn't contact me and ask me a question, I wouldn't have a job. So please always do contact us if you've got any concerns. But people would contact and say, sorry to bother you. It's probably nothing, but I'm worried about my itchy vulva, my mum's cervical cancer, whatever their gynae cancer concern is. And yes, most of the time it is probably nothing, because all of the symptoms for all of the gynae cancers are much more likely to be something less serious than gynae cancer. But of course, as a gynae cancer charity, it's our job to tell you the gynae cancer side of things. So yeah, most of the time it is probably nothing, which is great. But 58 women are diagnosed every day in the UK with one of the 5 gynae cancers: womb, ovarian, cervical, vulval, and vaginal. So we want to create the space to answer common questions, discuss important topics, and put your mind at rest, answer your questions. That's what we're here for. So March is Ovarian Cancer Awareness Month, if you didn't already know. The first episode of Series 4 was with Adiola Olaitan talking about the symptoms of ovarian cancer. Last week we did ovarian cancer treatment. So I've just been diagnosed, what now, with the wonderful Tracy Miles, who runs the service with me. And the third subject we're going to cover in relation to ovarian cancer is the topic of BRCA. So basically, about 15 to 17% of ovarian cancers are linked to a genetic alteration called the BRCA gene alteration. And it basically means if you have the BRCA gene alteration, you're at an increased lifetime risk of mainly breast and ovarian cancer. So the ovarian cancer side of it is where Eve come in. So my guest today, who I'm going to introduce and ask to explain all about BRCA. I don't even know if I've explained that correctly, so I'm going to get him in now. It's Dr. Adam Rosenthal, Consultant Gynaecologist and Medical Advisor of the Eve Appeal. I knew that I pestered you, Adam, when I needed questions, but I'm glad to know you have got the official title of Medical Advisor. That makes me feel a bit better for going, Adam, help me with this question.
Yeah, I signed up for it, so go ahead.
Okay, good. Okay, that makes me feel so much better. Adam, can you tell us a bit about yourself and your interest in BRCA and kind of what it is?
So I've had a sort of quite interesting circuitous career. Started off as a junior gynecologist, got interested in female cancers, and then got involved in research looking at ovarian cancer screening. As a relatively junior doctor, progressed through surgical training, became a cancer surgeon after many, many years of training, and now have really moved into primarily cancer prevention surgery. So I see women who've been identified as being at risk of a gynecological cancer. For example, they've had an abnormal cervical smear, or they've been found to have a change in one of their genes that they've inherited from their mum or their dad, which puts them at increased risk of cancer. And I'm then doing the necessary surgery to prevent them from getting a cancer in the first place, which is obviously a lot better than being diagnosed with cancer.
Yes, prevention is much better than cure. So you've got a lot of notches on your belt in terms of your gynae cancer career, and all before the age of 25. That is very impressive.
I wish.
I knew I would crack a smile. Adam's been saving lives and teaching today. This is the last set thing in his diary this evening's show, and I thought, do you know what? I'm going to get a smile out of him, and I've done it. So right, thanks everyone. Bye. No. Adam, okay, so I said at the beginning, today's session is about the BRCA gene alteration, because if you have it, you're at an increased risk of mainly breast and ovarian cancer. When we say gene alteration and BRCA gene alteration, what does that actually mean to someone that's never heard of that before, that phrase?
So the sort of the way we'd like to describe it is that the genes are the software of the cell, if you like. If your cells are computers, they need instructions as to how to run properly. And the genes are those instructions. And most of your genes get gradually altered as you get older through environmental factors that we don't always fully understand. But everyone knows that radiation is not good for your genes, for example. And if you live in the part of the world where there's a lot of radiation, then you're more likely to get cancer because of that. But similarly, you can be unlucky and be born with a problem with one of your genes that you've inherited from either your mum or your dad. It's important to remember that these genes, although that they cause predominantly cancers in women, they can be inherited from either side of the family. So don't ignore your father's family history of cancer. It may be just as important as your mother's family history of cancer. But essentially, you're born with a situation where every cell in your body has got mistakes in the software, and that software mistake makes it more likely for you to develop cancer, not usually when you're very, very young, but certainly at younger ages than average for that particular kind of cancer. So whereas in the general public, ovarian cancer tends to happen in the postmenopausal years when your periods have stopped after the age of 50, if you're unlucky enough to have inherited a mutation in BRCA1 or BRCA2, BRCA1 or BRCA2, depending on how you want to call them, you can be unlucky and develop a cancer under the age of 50.
And so you said it can increase your risk. So just so people are clear, you can't inherit cancer. So say my mum had ovarian cancer and is BRCA positive. I can't get cancer from her, but if I'm also positive, I've just got an increased lifetime risk. So it's the risk rather than the disease.
Absolutely. And the risk at most is going to be about 50-50. So even if you've got a BRCA1 or BRCA1 gene mutation, the lifetime risk of getting ovarian cancer is of the order of 1 in 2.
1 in 2. Okay. And you said BRCA1 and BRCA2. Is there much of a difference? So is it mainly breast and ovarian cancer that you're at increased risk of, or is that just if you have breasts and ovaries, but then, you know, my brother next to me is at equally a greater risk of another cancer that's relevant to his anatomy?
So good question. There are 2 issues here, I guess. The first is well, 3 actually. One would be the differences that the 2 genes have in terms of how likely you are to get breast and ovarian cancer. So the breast risk is very high for both of them, if you're a woman, but for BRCA1, the risk is higher for ovarian cancer than it is with BRCA2. So the risk of ovarian, as I just said, was about 1 in 2 for BRCA1, but is probably about 1 in 4 for BRCA2. So a bit of a lower risk there. The other thing is that the age at which it can cause ovarian cancer tends to be a bit younger in BRCA1 than in BRCA2. And then in terms of other cancers, BRCA2 seems to increase the risk of pancreatic cancer and also prostate cancer in men. They're not massively high risks. They're certainly nothing like as high as the risks of breast and ovarian cancer, but they are significantly higher than the background risk. Men can also get breast cancer. It's much lower than in women, but the risk can be increased with these genes as well.
And how common is BRCA? Like, is it, you know, my mum and my nan, touch wood, haven't had a breast or ovarian cancer, but how do I know they're not BRCA positive? Is it likely that we've got it in our family, we just haven't been unlucky enough yet to have a relevant cancer to get it kind of on our cancer team's radar?
So the good news, Karen, is that actually these mutations are not particularly common. And in the general public in Europe as a whole, it's probably around 1 in 500 women, give or take, as a ballpark figure. So it's not very common. There are some exceptions to that, and these would be certain ethnic groups that tend not to marry out. And the classic example of that are people of Ashkenazi Jewish heritage, where up to 1 in 40 people may carry one of these mutations.
So it's a lot more common in certain groups. For example, the Ashkenazi Jewish population. And so say my mum does have it. We'll talk about how you find out if you're BRCA positive in a minute. So say my mum knows she's BRCA positive and she's 60. She knows that's that. For whatever reason, she's had treatment and found out. Do I need to worry? Like, how likely is it as her daughter, I and my brother, is it likely we would have it? Is it kind of 1 in 10? Is it you definitely get it?
So actually, it's a very simple answer. It's 50-50. So if your mum carries one of these mutations, then it's 50% chance, 1 in 2 chance that you got the good copy of the gene from her, and a 50% or 1 in 2 chance you got the bad copy. And it's just like tossing a coin every time your mother has had a child. So whether you have it or not has no relevance to whether your brother has it or not. Neither of you have it. You might both have it, or one of you may have it, but whichever of you has what does not affect the risk of the other person having it.
I see. And say I was negative, could it then, so my mum has it, I do not. If I had a baby, would my baby be at risk, or does it stop once it's negative?
It stops with you. The exception would be if you were unlucky enough to have a baby with someone who carried the mutation themselves.
Yes.
But the odds are that's pretty unlikely.
So for most people, if they know they're BRCA negative, it is pretty highly likely that their baby will be negative as well, unless they've partnered with someone. Fine. So once it kind of stops, it stops. Now, okay, I guess the question is, how do people find out? Like, how do I know I'm not? Can I just randomly go and say, hello, GP, I'm worried because I worry about breast and ovarian cancer. Can I have a test?
So the NHS has to currently limit availability of gene testing because it's although it's not massively expensive, it's not that cheap either, although the cost is falling. And so the NHS constantly reevaluates the criteria that get you the test for free on the NHS. And the good thing is that over the years, the criteria have become less tricky to negotiate because the cost of gene testing has fallen, so the NHS can afford for more people to get tested. So the first route by which many women now, well, not many, some women are now diagnosed as carrying a BRCA mutation is because they themselves have had an ovarian cancer. And the interesting thing is that because being an ovarian cancer patient and knowing you have a BRCA mutation can change the treatment options and get you access to some very useful drugs that are having a very beneficial impact on patients with ovarian cancer. There's now much more focus on testing patients with ovarian cancer for these mutations because it can actually affect the treatments that they get offered. So that's one route by which women may find out that they're positive if they themselves have been found to have ovarian cancer. The more traditional route by which people found out was that they realized there was quite a lot of cancer in their family, maybe a lot of breast cancer, maybe one ovarian cancer, and maybe the breast cancers were at particularly young ages. And for whatever reason, they knew that that might be relevant. And they then went to their GP and said, listen, I'm pretty worried about this family history of cancer. I've got loads of breast cancer in my family. I've got an aunt that had ovarian cancer. Is there something going on here? And then an astute GP would have said, yeah, you have a very good point. And I'd actually like to refer you to the local clinical genetics service. And these are staffed by doctors and trained counsellors who will take the family history in detail and they will often do some work to confirm that family history, because you'd be surprised how often the families actually got it wrong. They think some families had a certain kind of cancer. When it's looked into in more detail, it turns out they didn't. But once it's been confirmed, then if they hit the right criteria, they will get offered the gene test on the NHS. It's important to point out that the GP can't refer just anybody with any family history. It has to fit criteria, and GPs are aware of what the local genetics centre will take as a referral. In other words, there has to be a certain strength of family history. It can't be that you've got just one relative who may be very distant with breast cancer. That's not going to be a strong enough family history to get you in. But if you've got lots and lots of breast cancer, particularly at young ages, or if there's an ovarian cancer as well, or if there's Jewish ancestry on the side of the family that has these cancers, then this might get you through the criteria to get referred in to the local NHS genetics service. I guess there are two other ways by which you might find out. It might be that a relative of yours has been found out to be positive, and the genetics service then contacts you with the permission of the family member who has tested positive, or the family member may approach you directly and say, I've tested positive. You need to see your GP and get referred to your local genetics centre so that they can offer you the test as well if you want it. And then the other way that's happening a little more frequently these days is because people have just done a test privately. They've seen something about it on the internet. They've decided they want to be tested, whether they have or haven't got a family history. If you've got the money, you can be tested. If you've not got any family history at all, the chances of that test being positive is actually not very high. If you've got a family history, the stronger the family history, the more likely there is to be something going on. And for that reason, you can often get the NHS testing for free. But if you maybe don't quite hit that threshold, but you're anxious about it, or you don't hit the threshold at all, you've got no family history at all, but you're just curious and you want to find out more, then you can, if you so wish, elect to pay for it privately. It's usually a few £100s to do that. But you have to be cautious about this in terms of making sure that it's an accredited laboratory that offers reliable testing, and also that they have some backup, and it's not just that they're going to give you a test result and leave you high and dry. You want to know that the company offering you that test will give you the necessary backup and counselling about what a positive and negative test result might mean. And you shouldn't embark on the testing without thinking through, well, what if it comes back positive? Because that's going to be a pretty scary situation to be in, particularly if it's something you've just done over the internet without actually having spoken to someone about it beforehand.
So say whether I went through private or NHS testing and I had a positive result. So say I'm 30 and I've got my BRCA positive result. I obviously, like anybody, don't want to get breast or ovarian cancer, but I'm now at a kind of much greater risk. What can I do? What happens?
Well, if you were diagnosed by the NHS Clinical Genetics Service, you would automatically receive the appropriate counselling about what your risk level is and what your options are for doing it. And the geneticists are sort of the gatekeepers for the ongoing care. So they will say to you, you may have an increased risk of breast cancer, and then they will offer you, if you're the right age, entry into a breast screening program for people who are known to be at increased risk. They may also offer you consultation with a breast surgeon who can talk to you about what your options might be for actually having surgery to remove and reconstruct your breasts to reduce your risk. Similarly, they may refer you when you're the appropriate age. 30 is probably a bit young, but we do see some women at that age just to talk to them about their risk, because the ovarian cancer prevention surgery is not usually considered under the age of 35. But if you're particularly anxious about it and want to know about what your options are, we will see you before that age. We also might see you before the age of 35 if you want to enter a particular trial that's going on at the moment called the Protector trial, which gives you the option of having your fallopian tubes removed only for the time being, and then coming back to have your ovaries removed at a later date. And if you like, Karen, I can talk about that in a little bit of detail. But it just to explain that the way you normally access this care is initially via the genetics teams.
And so you mentioned that if someone finds out their results, say, for example, they're 30, they will talk to, speak to lots of people, but essentially in terms of kind of preventing, it sounds like if things are going to be removed, it would be breasts first and ovaries later. In the sort of age 30, is that because
of the age-related risk? It's true that these genes cause breast cancer in more women than they cause ovarian cancer, and they cause the breast cancer at young ages often.
That was my next question. Exactly. Yeah.
So if you looked at it purely from a risk perspective, then yes, it might make sense to recommend it in that order. But it's going to be such an incredibly individual decision for every woman about whether she wants to have breast removing and reconstructing surgery, yes or no. Does she want to have ovary removing surgery, yes or no? Has she had children? Does she want to have children? Is she prepared to undergo premature menopause and to take HRT for many years? You can see that there are a lot of decisions that are incredibly important to each individual woman and will be different for each individual woman. So there are no hard and fast rules here, but purely from a risk perspective, the risk of breast cancer is higher at younger ages than the risk of ovarian cancer. So the woman might want to deal with that risk first, but equally she may decide to go for screening for breast cancer because that can be very effective in women with BRCA mutations. There's no guarantees. It certainly isn't guaranteed to prevent cancer. It at least is an option she can do while she's thinking about having the surgery. Unfortunately, the evidence so far on ovarian cancer screening is that it's not so effective. Not something that should be used as an excuse to delay the risk-reducing surgery for ovarian cancer indefinitely, but it's something you can perhaps choose to do while you're making up your mind about having the surgery, but don't let it give you endless false reassurance, because undoubtedly for ovarian cancer prevention, surgery is the right thing to do. The question is not if you should have it, you should have it. The question is when.
When.
That's a difficult decision that women face. Do they put it off until they've been through natural menopause, which means it's causing them far less hassle. There is a risk of them developing a cancer before natural menopause, and unfortunately at that point it's much harder to deal with.
So of course it's not just reducing your risk of cancer, is it? It's it's the fertility and emotions and life decisions that brings up, but also the physical process of going through menopause. So it's not just I'll reduce my risk and I'll do that. There's huge physical trauma, life decisions, emotions. It's a huge thing to decide, isn't it?
Yeah, I think the direct physical trauma of breast surgery is clearly much greater than the direct physical trauma of ovarian surgery, which is usually done with a keyhole operation as a day case thing, and you get over it very quickly in terms of scars and the pain. It's the effect of premature menopause, and although hormone replacement therapy is very good at alleviating many of the symptoms and many of the long-term downsides, it's not perfect. And no self-respecting gynecologist is going to sit in front of you and tell you, don't worry, if you take HRT, you'll be absolutely fine. We can't guarantee that. Some women actually feel better. I mean, if you've had very bad premenstrual syndrome, funnily enough, taking your ovaries out and going onto a more stable level of hormone than you were experiencing with your menstrual cycle can actually make you feel better. And I've had some patients who say to me, I wish I'd done the surgery ages ago because it's made me feel better. But unfortunately, that's not true of everyone. And there'll be some women who don't feel any difference at all. And there'll be other women who actually say, I really don't feel happy on this HRT. And We might send them to a menopause clinic so that they can have real experts sort of tinker with the HRT type and dosage and try and get something that works for them. But there's always going to be a minority of women who just don't feel entirely happy. And whilst they will be hopefully very pleased that their risk of a potentially fatal cancer has been taken away, they will be suffering some long-term side effects from that, be they psychological or physical, or possibly a combination of the two. So you can see it's a really tough decision that women have to make, and it's not something that we expect them to make overnight. And it might take more than one consultation over a period of time, maybe even years, before they make their decision. But the key thing is not to put it on the back burner forever. Because unfortunately, some women might come a cropper if they do that and get cancer while they're making up their mind. I'm not saying that to bully or panic them into making a decision too quickly. You never need to make the decision tomorrow. It'd be good if you could make it over a period of maybe 1 or 2 years rather than put it off for 10, 15, 20 years, because that's when you're going to get unlucky potentially and develop a cancer.
And in terms of kind of anecdotally in your experience with patients, do you find there's a correlation between, so say a woman is diagnosed with ovarian cancer, offered testing, takes the testing, she's positive, she has 3 children, so they are automatically eligible because they have got a 50-50 chance of being BRCA positive. Do you find there's a correlation with, for example, the 3 children in question? Say 2 out of the 3 want to find out their status. Would you, in your experience, kind of tend to expect the ones that want to find out, it's more because they want to take action if positive, or because they simply just want to know? Like, do you tend to find that once someone knows they're positive, the uptake of preventative surgery is quite high?
I think, to answer that honestly, it's slightly difficult for me to give you an unbiased view, because I only get sent, by and large, the women who are at least contemplating the surgery. Because I guess the genetics teams don't want to send me lots of patients, just to get a bit more information if they're not contemplating the surgery at all. I mean, I do see people who get referred because they really just want to find out more information and they're particularly anxious about it. I think the main motivators for people coming to get the surgery are because they've seen a relative who's actually had the cancer themselves. There is data on this, and we know that amongst BRCA carriers, those that are most willing to opt for risk-reducing ovarian surgery are those in whom there is a relative who's had an ovarian cancer. And that's understandable, because if you're a BRCA carrier but there's been no ovarian cancer in your family, it's a much more abstract concept. There's some healthcare
it's not there in your face,
telling me I'm at increased risk, but I don't actually know anything about this disease. I've got no relatives who've had it.
There's no reality for them, is there?
Exactly. But if your mother or your sister or your aunt or your grandmother have had this dreadful disease and you've actually seen them suffer from it, then of course you're inherently going to feel an urge to protect yourself and try and avoid getting that condition. There will be some women who are actually just so terrified, having seen what it did to a relative, that they will actually not want the test at all, because they won't want it. What I'd say to them is please try and get yourself to a state where you're willing to have the test. Because first of all, it's 50-50, it could be good news, and then you'll have nothing to worry about. But if it is bad news and you do have the gene mutation that your mum had and made her get ovarian cancer, there is stuff we can do for you. And most big clinics such as our own do have access to a health psychologist who can help you make these difficult decisions in the first place, to have the test or not. And they can help you unpick what is it that's really holding you back from having this test. What is it that's frightening you about it? Helping you to confront your fears. Just as, people who are scared of going on an aeroplane can see a psychologist and eventually overcome their fear and fly. and that's to go on holiday. What we're talking about here is a test that, if you're positive, gives you the option of having surgery that can save your life. That's more important than taking a plane to go on a holiday. So the NHS recognises this, and it will provide, if you go to the right people, it will provide you with a health psychologist who can help you make up your mind about having the test, and then hopefully make you happy with that decision. And then if you've had the test and you're positive and you're having real difficulty deciding on if you want to go for the surgery or not, and I'm glad to say we don't see that many people in that position. The vast majority are quite capable of making up their minds on their own without the help of another healthcare professional. But if you are finding it difficult, and I'm not saying there's anything difficult about you, everyone is different, and I totally understand that these are really hard decisions to make, balancing risks of getting cancer against being told you can't have kids at all, or you can't have kids anymore when you've already had one or two, or having to take HRT for 10 years or more. These are huge decisions. You're not being difficult if you're asking for help in making up those decisions. But there are people who can help you with that, not just your friends and relatives, but people who can actually help you psychologically and guide you through the process.
That reminds me, I was talking to this lady once, and she, her mum had ovarian cancer, BRCA positive. So she got the test and she was negative, which is great. But she has a brother who was obviously at equal 50-50 risk, and he refused to do the test because he said, I don't want to know. But the lady I was speaking to was so worried because her brother, who didn't want the test, had 2 daughters, and she was saying she didn't have children herself, but she was saying the nieces are like my own children, and I want them to know as they grow up if they're at this increased risk. But the brother was refusing, so it was a really difficult situation there, because and obviously it's not that he didn't want to protect his daughters, he just himself, I mean, I'm sure they maybe eventually spoke to somebody like you suggested, but it was interesting in those early days where he just couldn't, and therefore that meant his daughters wouldn't find out unless he did.
So it depends on the daughter's ages, actually, because if they're under 18, then they're not going to get gene tested anyway. The NHS
won't. Of course, yeah.
But if the daughters were 18 and they're therefore adults, they're obviously allowed to make up their own mind, and therefore, this particular lady that talked to you about the situation, she'd be no doubt risking her popularity within the family. But if the children were 18, she would be totally within her rights legally to inform them that she had a mutation. And now these girls are 18, they can approach their GP as independent adults and say, my auntie's told me about this and I'd like to get tested. But actually, there would be no hurry for that information because no one is going to offer them any kind of ovarian surgery until they're at least 35. Breast surgery is being offered at increasingly young ages, but usually it's not going to be in someone under the age of 20. And most women having the preventive breast surgery or having breast screening are much older than that.
And just before we kind of end with the research, that I'd love to end with that. A couple of kind of just random, let's go quick fire questions. So, is BRCA-related ovarian cancer worse than non-BRCA related ovarian cancer in terms of kind of outlook, treatment?
So, I mean, patients with BRCA carrier patients who are BRCA carriers get one specific kind of ovarian cancer called high-grade serous ovarian cancer.
So there is a sort of ovarian cancer type kind of assigned to
there are
BRCA
many different
in a way.
types of ovarian cancer. It's not just one disease. And BRCA carriers almost exclusively, there's always going to be exceptions, but almost exclusively get this one type. This one type is also coincidentally the commonest type in the general public, but it seems that BRCA carriers tend to do a bit better, at least up to about the 10-year point, than people in the general public who have that same kind of cancer, if that makes sense.
Yes, it does. I said 15 to 70% earlier, but correct me if I'm wrong. What percentage of ovarian cancers are BRCA related?
So what was the percentage you said again? I couldn't quite hear that.
I said between 15 and 17-ish. Am I lying?
I think a ballpark figure of 1 in 10 is probably overall. But if you look at specifically high-grade serous cancer, ovarian cancer, then the proportion will be higher.
Okay, so my mum, this isn't me, but somebody's written in, my mum had breast cancer when she was 40. So I don't qualify. Do I qualify for testing? Because they know they haven't got kind of more than one relative. But does the fact that a mother, so a very close relative, a 40-year-old breast cancer in a mum, does that worry you? Or is it just that breast cancer is one of the big four and life happens and it's rubbish?
So there are more questions I, as a doctor, would want to ask.
Yeah.
One is the absence of a family history, which is important. Other factors that a geneticist would take into account would be how big is the family? Are there lots of women in the family or not?
Good point. Really good point. Yeah.
Anyone who got a breast cancer, then that's clearly relevant. If her mum had something called triple negative breast cancer, then that is one that's more likely to be associated with a BRCA mutation, and in fact would probably get the mother into getting gene tested herself, or just on her own. Just being 40 and being triple negative breast cancer, she should be offered BRCA testing by the NHS. But the other thing is if there's any Jewish heritage, again, because if there was Jewish ancestry and an early onset breast cancer, then that sets alarm bells ringing. But in terms of whether she herself is eligible for gene testing, I don't carry around in my head the referral criteria, but you can go onto the local clinical genetics service website and they will have the referral criteria that GPs will need to look at to decide who does and doesn't fit the referral criteria. And if you're confused by that, ask your GP to look at it for you, and that they can interpret it for you in the light of your own family history.
So before we wrap up with research, if you are concerned and think, you've got a family history, you're worried, your GP is your first point of call. So if someone's watching this and thinks, yeah, something's not right, family history wise, the GP is the first person you speak to.
Yeah, I think that's the current route of as how the NHS model works. But I think you need to be empowered with the knowledge that's relevant. So it's things like saying, I've got breast and ovarian cancer in the family, not just I've got breast cancer. Also say I've got prostate cancer and pancreatic cancer in the family, if that's going on as well. If you're of a specific ethnic group, that may be relevant. As I've already mentioned, Ashkenazi Jewish. There's also certain Polish mutations, as they're called, that are more popular, for want of a better word, in people of Polish extraction. There are lots of little ethnic subgroups. I mean, England is such a multicultural country. There are people from all over the world here. It's one of the things that makes it such a great country. And working in London's wonderful because of it. But it does mean that we've got lots of little ethnic groups that have particular medical conditions that are specific to them, just because they haven't yet, because they've perhaps only been in the country for 1 or 2 generations. They're not completely mixed up with everyone else yet. So they're still more likely to have certain conditions than other ethnic groups might be. So yeah, look up information about BRCA on the internet, find out more about what the other cancers are it can cause. Of course, these cancers all have to be on the same side of the family for it to be relevant. But go to your GP, and if you're getting short shrift from them, just say, look, I know it's only one cancer, but it's at a really young age, and I'm Jewish, or whatever the issue is. And then get them to look up the referral criteria for the local clinical genetics service. But I think these days most GPs are pretty good on it.
And research, kind of ending on a looking to the future, what is going on at the moment in terms of BRCA research that you're involved with, that if someone's listening and has just found out they're BRCA positive, etc., what can you kind of tell us that people might be able to get involved in, or any kind of updates?
So I already mentioned the exciting trial that's being led by Queen Mary University London, and there are many centres, including our own at UCLH, around the country recruiting to this. And this is a trial that allows you to have your fallopian tubes removed first and to come back to have your ovaries removed at a later date. That's called the Protector trial. And the advantage there is that we think it'll offer you substantial protection against ovarian cancer without the same hormonal problems that having a premature menopause causes. We don't yet have proof of that. That's one of the reasons this trial is running. But it may be that you can get almost as much protection as if you have your ovaries removed as well, without as many side effects. So that's exciting. We've been working on a surveillance program for women with a BRCA mutation to try and detect ovarian cancer earlier, and it does look like it detects it earlier, but it's not yet available routinely on the NHS, and we're going through the process of seeing if it may be cost effective to help persuade the NHS it might be worth doing. And then much of the work that the Eve Appeal done is looking at better screening tests that could diagnose cancer much earlier, and that is looking really exciting. And it's possible within the next few years there'll be a test based on a cervical screening or cervical smear, as we used to call it, sample, which may be able to tell you not only your risk of developing cervical cancer, but also your risk of ovarian, womb, and breast cancer. And that's really exciting. And that's still a few years off, but very much looking like it's going to happen, given enough time, effort, and of course, research money, which is always the issue for us.
Adam, go back into the green room and I'll say goodbye to you properly then. But for now, for our audience, thank you so much. And I think you answered lots of people's kind of really sort of pressing questions, because, you know, if you know you're at an increased risk, you know, a much greater risk than the person next to you, there are so many things that you need answering and are worried about. And I think, yeah, you've done an amazing job in helping. Thank you so much.
It's a pleasure, as always.
Thank you. Yay! I think that was such a helpful, informative session. So thank you so much if you watched it live. We always put up all of these episodes on our social media channels and YouTube channel, so you can catch up whenever you want. There's no rush at all. You can take a break and come back to it later if it's too much to digest in one go. However you want to absorb, probably nothing. We are just grateful that you're watching and supporting us. Yeah, so thanks so much for watching. We are back next week with a wonderful GP. So we're going to be answering kind of general gynae questions to ask a GP. So if you've got anything you want me to ask, please do email probablynothing@eveappeal.org.uk. But Tracy and I are available via Ask Eve for your gynae cancer questions whenever you want, not probably nothing related. So that email address is nurse@eveappeal.org.uk. Thanks again for watching, and we'll see you next week for Series 4, Episode 4. Until then, stay safe.